Next talk is viral retinitis, emergency uveitis, by me. 10 minutes. 10 minutes. I'll be talking on viral retinitis, which is an emergency in uvea practice. Let me start with a case. This is a 30-year-old female, immunocompetent. And if you look at the macula, you could see that there is a necrotizing retinitis lesions with hemorrhages. What is your diagnosis? You don't have to look into the diagnosis much, but if you look at the patient as a whole, you can get a significant clue. There is a vesicular rash of herpes zoster on the forehead. And this patient actually had varicose zoster retinitis, very unusual manifestation. And this patient responded dramatically after IV acyclovir for 7 days. So it was published. So in fact, viral retinitis is not only have varied manifestation, often vision threatening, requires prompt treatment and prompt diagnosis. It can occur both immunocompetent and immunosuppressed. Immunocompetent patients can have acute retinal necrosis. Rarely, immunosuppressed patients can also have acute retinal necrosis, can have HSV retinitis, HZB retinitis, rubella retinopathy, chikungunya, and dengue. Immunosuppressed patients exclusively have HIV retinopathy, CMV retinitis, progressive outer retinal necrosis, and rarely acute retinal necrosis. I'll start again with a case. He's a 42-year-old male, sudden dimness of vision for 1 week, diagnosed as chorioretinitis elsewhere. If the vision in the left eye was hand movement due to the previous chickenpox infection, right eye was 6, 18, and 12. Anterior segment was quiet except few pigments on the anterior surface of the lens. And if you look at the fundus, it has got very typical phenotype, characteristics wedge-shaped lesion with retinal vasculitis, vitritis, and little papillitis. What is your diagnosis and what test you will do? The diagnosis is quite obvious with this phenotype, acute retinal necrosis, peripheral necrotizing retinitis. What is acute retinal necrosis? It's a kind of a necrotizing retinitis, occlusive retinal vasculitis, and vitritis, triad of the three. And what test you will do? Serology for other viruses are useless except ELISA for HIV to rule out underlying HIV infection. And what the patient requires is the anterior chamber tap or vitreous biopsy for polymerase chain reaction. And this should be done for the nested and real time for herpes simplex type 1, type 2, varicose zoster virus, and cytomegalovirus. Virus cannot be cultured easily and it takes a long time. So polymerase chain reaction is the right way to go. And in fact, is the ACTAP or PCR for HZB was positive in this case. So it is an emergency in uvea practice, and it causes usually varicose zoster virus, rarely HSV1, HSV2, cytomegalovirus, and recently Epstein-Barr virus has also found to cause viral retinitis. Anterior segment acute anterior uveitis can be sometimes associated with it. Raised intraocular pressure is often quite characteristic, and vitreous cells can be seen. And this is typical wedge-shaped retinal lesion, peripheral necrotizing retinitis involving the almost 360 degree in the periphery and retinal vasculitis. One can have retinal detachment and very typical of having large atrophic retinal holes. And this is a breaks which is seen in a case of acute retinal necrosis. They have got such a characteristic clinical pictures can be diagnosed easily, but can mimic sometimes CMV retinitis, syphilitic retinitis, toxoplasmosis. One of the conditions which I have seen missed by some other people like peripheral serpeginoid choroiditis. This patient was thought to be acute retinal necrosis, but if you look carefully, the lesions is deep in the choroid and there is a central area is clear. And this is actually a peripheral serpeginoid choroiditis which responded well with steroid. So rapid circumferential spread over 7 to 10 days makes it an emergency. Fellow eye involvement 33% cases. Retinal detachment common in untreated cases, same like peripheral retina, multiple atrophic holes. They require medical treatment urgently, sometimes laser photocoagulations and surgical. And intravenous acyclovir is the common modality of the treatment. I give 500 milligram every 8 hourly for 7 to 10 days. After 48 to 72 hours, oral prednisolone 1 to 1.5 milligram per kilogram of the body weight. HIV positive patients add antiretroviral therapy. How long to give the IRN treatment medically? Is the minimum 3 months? Nobody knows that how long it should be continued. You should give oral acyclovir 800 milligram 5 times daily or oral val acyclovir 1 gram 3 times per daily and taper oral steroid gradually. And this is a case which I have shown to you, and within 3 days there is a significant resolution of inflammation, and day 8 there is a maximum resolution of inflammation, and after a month there is a complete resolution of inflammation. What's new is the oral antiviral therapy. It should be given in high doses, 1 to 1.5 gram 3 times per day. And photocoagulation is a controversial. Some people do it as a prophylactic laser photocoagulation to create new ora serrata. The vitreous surgery is often required because they develop dense vitreous opacity, vitreous membranes, and retinal detachment. Diagnostic vitrectomy can be done when the AC-type is negative and where there is a strong suspicion of viral retinitis. Vitrectomy, endolaser, and there should be always silicone oil tamponade. And here is a picture showing the vitrectomy. Unfortunately, that only 45% patients only had good visual recovery. 55% patients doesn't have much good visual recovery. Now shift gear to a immunosuppressed patients which developed exclusively CMV retinitis. We studied in the ocular lesion in 100 consecutive patients, and this is 8th era, and found 17% patients had CMV retinitis, which is the most common ocular lesion. This can be seen in the organ transplant patients or the patients with cancer therapy, cancer chemotherapy, and their picture is very characteristic. So once we have seen one case of CMV retinitis, we may not miss again. It has a dry granular whitish patch, necrotizing retinitis with hemorrhages, perivascular distribution, and often takes up a pizza pie appearance. And this is the posterior pole involvement, nasal quadrant, perivascular distribution, and can be isolated peripheral lesion and can involve the multiple quadrants, can have the frosted branch angiitis appearance. And if you don't treat it, it goes to the atrophic of the optic nerve and the thinning of the retina. The treatment is the intravitreal ganciclovir and oral valganciclovir. The implant and intravenous injection is no longer adopted now. Ganciclovir is 2000 microgram twice weekly induction and 2000 microgram once a week maintenance. And the high dose of intravitreal ganciclovir can be contemplated, can be obtained by the intravitreal ganciclovir. Oral valganciclovir is a new alternative for treatment, good viability, avoid the risk of local complication at the infusion site. This is a 450 milligram tablet, two times daily till the resolution occurs. Retinal detachment requires plasma vitrectomy, silicone oil tamponade, with retinal detachment can occur 33% of the cases. Now coming to the progressive route of retinal necrosis, fortunately it is rare. There is no anterior chamber or vitreous reaction in this case, no vasculitis, but there is optic nerve involvement, poor response to treatment, can be associated with the varicose zoster virus relationship. We have described in CMV also. Severe multifocal, deep, dense retinal necrotic lesion without vessel involvement. And it mimic a acute retinal necrosis or cytomegalovirus retinitis. Rhegmatogenous retinal detachment is quite common. Papillitis or neuroretinitis. 85 to 100% patients present with the unilateral disease progress to have bilateral involvement. CDC guidelines says that every acyclovir 10 milligram 8 hourly combined with the foscarnet, very poor response, retinal detachment, poor response to antiviral therapy. Toxoplasmic retinochoroiditis can mimic viral retinitis, and Here is a case which was thought to be CMV retinitis and was treated with the antiviral treatment, ganciclovir therapy, did not respond. Retinochoroidal biopsy was taken, and retinochoroidal biopsy showed Toxoplasma gondii cyst. And this is last is a post-fever retinitis. It can be dengue, chikungunya, typhoid, rickettsia, chickenpox. But I don't want to discuss in details due to the paucity of time. In summary, the viral retinitis is an important cause of sudden visual loss and is an emergency, often an important sign of underlying disease like HIV. Molecular dialogic studies can be of intraocular fluid like PCR can confirm the diagnosis, but the phenotype is often characteristics in like acute retinal necrosis, CMV retinitis. May need laser and vitreous surgery in many cases. Rapidly progressing, visual prognosis is often not good. Prompt and proper treatment can only salvage the vision. Thank you very much.